How's everybody doing? This is the ethics part, which everybody gets really excited about, or doesn't. So this could get weird. Is everybody ready for the ethics part? No? Okay. So I'm going to talk. I'm Allan Peetz. I'm a trauma surgeon at Vanderbilt, and I also do. I'm also on faculty at the Center for Bioethics there, and my research is in trauma surgery ethics. And I'm going to talk a little bit about the ethics of resident autonomy. And this is the obligatory outline here, and I want to talk. Just kind of go through what exactly I want to discuss. And what I want to start out with is why we're talking about this at a surgical conference and why it's important to talk about surgery and resident autonomy and how it's different than medical, the medical training and why that's different. We already talked about Mike Wallace, but I think it's pertinent to answering that question. And then I want to lead into the question that's central to this, to the ethical question here, which is, do future patients have rights? And to help answer that question, I want to ask another question, which is an annoying thing that ethicists do, which is to answer questions with a follow-up question, which is, how do you make a human thumb? And I promise you that that will help, or that there's a good chance that that will help answer that question. And then I'm going to follow up with my initial attempt at answering the question, and then finally answering the question. So why are we talking about this in a conference in general? The resident autonomy issue is usually tied together with patient safety issues, like our previous talk by Dr. Sachs, and resident autonomy and patient autonomy, like the patient who asks for the resident not to be involved. Libby Zion is often referenced to, which led to our change in resident work hours. But surgical training is different, and those differences are real, and they're important, ethical considerations that I think have practical implications for how we move forward and how we respond to the potential policy implications on how we train our residents. Because there's not a one-size-fits-all, even though sometimes that's what's proposed for all residents that are training. So our training is to take medical students and to give them a knife and to teach them how to do something to a human, invasive things, real things that can change their lives forever, for good and for bad. And the potential is to have them have these changes to be life-altering, life-ending consequences. They're real, and that can happen in medicine too. But the risk is much higher in surgery, and all in the context of a patient who's asleep under anesthesia. And you can make an argument this is the most vulnerable state that a human could be in. And this is a real difference compared to any other training that you have. We already talked about Mike Wallace, but in comparison to Libby Zion, this was really kind of the seminal change in surgical training. Libby Zion was important because it resulted in a real legal case that people reference, but this was the first public definition of ghost surgery. Ghost surgery had been a term that was defined a few years prior, but Mike Wallace, when he was working for 60 Minutes, brought this to light, and this resulted in this resulted in the public kind of questioning the surgical training paradigm. Because what happened in this 60 Minutes episode was they used some kind of subversive journalistic techniques, which were necessary to uncover the story, and we can debate that at some other time. But what they did was they showed how training was done, which was that this chief resident was doing an operation completely by themselves. When they showed the video at the end, the patient was surprised that that wasn't what they expected the operation to have looked like. And she was ticked off, and she kind of represented what the public also felt about it, which was that they felt like they had been lied to. And that resulted in what one of my colleagues, who's an ENT surgeon, would say, and I stole this quote from him, was that a natural endpoint of internal dishonesty is external oversight. And that's what leads us to what we see now, which is we all know what it was before the 60 Minutes story. We've all heard the stories. I did my training inside or after the resident work hour implementation, but the resident only cases now, the data shows about less than 2% of all cases are resident only. Now, is that a good thing or a bad thing? I don't know. But there's this really interesting, comprehensive article with Dr. Pellegrini and Hoyt that is comprehensive, and it's not just about a resident autonomy, but it asks this very good, pertinent question for this debate about, are we going to have any good general surgeons? And I think that that's what we're all asking ourselves about autonomy. When I know personally, and this is anecdotal, autonomy's necessary. I don't know how else to learn operations effectively than to do it yourself. I just don't know a better way to do it. We've tried simulations, pigs, sheep. Visualization. There's tons of different ways to try to do it, but doing it yourself is the best way, and sometimes that's the only way to really actually learn it. And this is something that we need to ask ourselves about. When we're push this number in one direction, is this something that we should be doing? A quick side story that's worth mentioning, that's a completely other ethics talk. The 2% is a statistic, and because it's a statistic, it has a distribution, and there is variation around that norm. There is obviously, and there's data to show that there is more autonomy related to less financially supported patients. Now, whether that's good or bad, I'm not saying anything about that. This is a very complex issue, and I'm a trauma surgeon. And certainly, my residents, actually there's some of my previous residents in the audience right now, have operated autonomously. I promise you they will say that. I'm not saying anything, I'm just saying it's worth mentioning, and it's worth mentioning that it's a complex issue. That I'm going to ignore. So back to the main story. Is this a good thing or a bad thing? Tons of literature out there about this complex issue, about readiness for practice. It is a hard thing to nail down. Autonomy is only one thing, but that's what we're talking about. Because I'm an ethicist, and this is an ethics talk, I tried to pick something out of all of the things I researched that was representative. This was the thing that I found that was representative because of its unsettling numbers. This is not a journal club, so I don't want to kind of nitpick the details, but just kind of go with the broader implications, taking it at face value. But this was a survey of fellowship directors about their first-year fellows. These are MIS, thoracic, HPB fellowships, about their fellows' ability to operate, about their first-year fellows' ability to operate. And this is what they said about their first-year fellows. So ostensibly, general surgeons, right? 20% couldn't operate on day one. 66% of them, they said about 66% of their fellows, they would not leave in the OR for more than 30 minutes. The thing, as an acute care surgeon who does lap choles probably more often than he really wants to, 38% could not do a lap chole on their own. This is a general surgeon who can't do general surgery. And a general surgeon who cannot do lap choles is an ethical problem. This is a trolley problem. I don't know if anybody has ever come across this, but this is a classic ethical experiment. And it's basically what this is right here. I think that's what we're kind of facing. It reminded me of that. The trolley problem is basically this. There's a trolley running down a hill, and it is, right now, it's heading toward those 5 people. You are the attending, standing next to this lever. If you do nothing, it's going toward those 5 people. If you press the lever, it will divert toward the one person. If you do nothing, it'll go toward the 5 people. So it sort of feels like that a little bit. And if you think about it in terms of training, we're all training these residents to be surgeons who might operate on us one day. The variation sort of feels a little bit like this. And then if we think about it more of a policy kind of level, maybe it feels like this. And I think that kind of leads me into the question that I was alluding to earlier about the future patient, does the future patient have rights? And that is where leads me to the operating room where we live day to day, where this feels the most pertinent, where I hear this voice the most, the loudest, as somebody who cares deeply about my patients and deeply about the residents across from me, and being a good teacher and is learning every day about how to be better than I am, because I'm not great at it yet. But I remember as a resident, I felt like the answer to this question was, hell yeah, that's my job. is to learn how to be a better surgeon for my patients when I graduate. And now, I don't know the answer to that question. Stop asking me questions. Let's just get on with our day. But that's brings me to this question of, I don't know how to answer this question, but if you allow me really quickly to divert some attention to this weird detour, I don't know, 73% of you will agree that this might help answer this question. It was, just bear with me. So, does a future patient have rights? Let's talk about how you make a human thumb. So, there's a small percentage of boys and girls in the United States that are born without a thumb each year. It's called hypoplastic thumb. It's about 1 in 500,000 births. And of those boys and girls, some of them have available to have this weird, amazing, ridiculous operation called a policization, which is just a fancy word for make a thumb, where you rotate usually it's an index finger, and make a thumb out of it. It's a very specialized operation where you have a very low incidence of potential operative candidates. Expertise is really hard to develop. You have to do an ortho or plastic residency, a hand fellowship, and then a pediatric hand fellowship, and then you have to specialize training in policization, and then you have to be in a place where you have a patient population that can maintain those skills. It's quite ridiculous. And I was reflecting on this while I was reflecting on maintaining those kind of skills in comparison to that 38% number, the 38% of graduating residents who cannot do lap choles, when I was thinking about is it possible that we're going to lose out on not only are we doing a poor job on is this autonomy issue not only resulting in poor training and delaying training for our residents, but will it also ultimately result in the loss of these more specialized procedures? I was thinking about this because this is my daughter, who is, I think we will all agree, objectively adorable. But she was born with a hypoplastic thumb. And it was interesting to think about this not as a surgeon, but as a father who, as a father, I don't give a crap about the surgeon's resident training. I want you to be the most trained individual around. And over the past 6 months, we've been looking around for finding a surgeon. And it's been interesting to think about this and reflect on what the possible effects of inadequate training would be for the future patients who would have surgical indications for things that might need highly specialized training. And would those even exist? I don't know what the answer to that is, but it was an interesting thing to think about, not as a surgeon, but from a personal standpoint. So I think I'm probably out of time, but so we will skip over my initial thoughts. I think that to kind of wrap in what the previous data shows, which is that harm and residency training are not necessarily are not necessarily hand in hand, and that the clear answer to this is none. That I think to answer this question directly, both from an ethical standpoint and from a practical standpoint, that the patient, how much can this patient be harmed to help the next one the answer is none, but because we're doing surgery, we will harm some patients, and that part of that is learning as much as we can from those patients, and that a part of surgical training is to teach residents and trainees how to learn from those errors, complications, to help the next one as much as possible.